Hello? Hear me? Can you hear me?
Yes, we can.
You guys hear me? What are you supposed to do? I was clapping, that wasn't working. Can you hear me? Can everybody hear me? Okay, sorry. Can you hear me, Jennifer? Was on a minute ago. Just not loud enough. Does anybody know how to make it louder? Who teaches in here? Oh, sorry, Sarah. How about if I start? Can you hear me for the introduction? Oh, all of a sudden you can definitely, that's loud, Charmaine.
Yeah, I know.
I know,
Trying to find a happy medium.
All right. Hello, everyone. Thanks for coming to Food for Thought today and SMS. It's great to see all of you and a full room. I'm very excited. This meeting is being recorded. I think I probably should say got it. 1 second. Okay. I'm very happy to have that we're able to have Dr. Nadia Islam join us today. I feel like maybe I'm not the best one to introduce her since she's been known around here for what, 20 years, something like that, right, Dr. Hopper? How many of you are MPH students? I believe that Dr. Hopper told me that Nadia was his first TA in social determinants class, and Hopper's been here for a while. So anyway, this says nothing about Nadia, maybe something about you, Dr. Hopper. Good, I think we're good. Thanks, Simon. So I'll just give a brief introduction so we can let Dr. Islam proceed, but let me just say she's a tenured associate professor in the Department of Population Health at the NYU School of Medicine. It's implied, but I guess I haven't said it. We're very proud of her as an alum from SMS from a few years ago. It's up to her to tell us when that happened, as far as I'm concerned, but her focus was on medical sociology. So she's been a real superstar, is a real superstar, and we're very happy to be able to have had her study with us. I actually had the pleasure of meeting her at the 50th anniversary of this department, which we realized was approaching almost 5 years ago now. So Hopper has not been here for 50 years. Just wanting to just clarify that little data point. So Nadia has a number of other really outstanding roles at NYU. You can see from her talk title how community focused she is. And this is reflected in a number of leadership positions that she has. That includes the Director of Cardiovascular Disease and Diabetes within the Center for the Study of Asian American Health. She's the co-director of Community Engagement and Population Health Research in their Clinical Translational Science Institute, as well as the Associate Director and Community Engagement on the Langone Institute for Excellence on Health Equity. So there are many other numerous accolades of this nature in her CV, an outstanding record of NIH funding, numerous publications, outstanding mentorship, and I think I'll just stop there because I'm sure you mostly want to hear her talk. So let's just give her a very warm welcome. We'll go from there.
Thank you so much, Kathy. Can everyone hear me? Yeah. Thank you so much. It's always a little, embarrassing to be introduced, but really appreciate the warm welcome. And it's like both a true joy and a total trip being back here. SMS and my time here was transformational in so many ways. I made some of my dearest lifelong friends here. I had inspiring mentors, including Hopper, who is also a friend. He was at my wedding in Dallas many years ago. I made connections that really launched my career. And really, I think, it really instilled in me the strategies and the tools and the importance of applying kind of theory-driven critical thought to public health. And so, I hope that continues to sort of be infused in my work. I'm really thrilled to have the opportunity to share our experience on bridging clinic and community settings to advance health equity across diverse communities. So I want to, down button's not working. Use the clicker. Something seems to be stuck. All right, here we go. So I want to start off by sharing a little bit about my journey, which I think is important. You know, my story is fundamentally an immigrant story and has really been a driving force of my work. So these are my beautiful parents on their wedding day. My parents were immigrants from Bangladesh to the United States in 1968. And in 1972, they moved to Dallas, Texas, where they were the first Bangladeshi immigrants in all of Dallas. And, you know, you can imagine 1972 Texas, you know, they were othered in many ways. And they played a really important role in community building. So I have a huge extended family in Bangladesh, but we never had any of that family here growing up. And so they really were here without the kind of emotional support, the instrumental support, the social support that family provides. And instead, they really made connections to other Bangladeshi community members, other South Asian immigrant community members, other immigrant community members through cultural and religious events, gatherings at our home, and also just kind of shared community spaces like ethnic grocery stores and ethnic restaurants. And so, you know, my interest and commitment to health equity has really grown out of that, you know, really a recognition of the critical role communities play, particularly for communities that can otherwise feel invisible. And so kind of my pre-Columbia life, I got my start in kind of immigrant rights organizing and grassroots community-based organizational social service delivery. And those experiences really helped me understand how, you know, community service, research, advocacy, they're all very much connected. And it's really shaped kind of the direction of my research, which I hope you'll see. And I see Bob peeking in on the back over there. Hi, Bob, good to see you. So now broadly, my research focuses on how we can better connect communities to healthcare systems in ways that are culturally and socially responsive. So I'm going to focus my talk today on the work we've done with community health workers, with really a focus on kind of describing who CHWs are, what this model looks like, and how we've integrated CHWs into both community and clinical settings to focus on diabetes prevention and management. So I'll start off with a little bit of background on the community health worker model and their role in addressing the social determinants of health. So I'm sure many of you have seen this graphic. It's created by Dr. Kamara Jones that really portrays the social determinants of health or the root causes of health using this metaphor of a cliff. So, you know, social determinants of health are kind of at the top of the cliff. And as clinicians and public health professionals, we tend to focus a lot of our effort on what happens after we've already fallen off the cliff, right? We focus a lot of our effort on, you know, best case scenario, primary prevention, but more frequently kind of safety net programs, secondary prevention and medical care. But, you know, those are systems that have been created to work with vulnerable populations once they've already fallen off. So to make the biggest impact in reducing disparities, we want to think about programs and policies that are addressing kind of root causes or, you know, fundamental causes in our kind of SMS Lincoln Phelan speak. So if we want to think about working across these levels, we need to think about models that bridge kind of community context to clinical and other systems of care. And so the community health worker model is kind of one such model for doing that. The CHWs, community health workers, are frontline public health professionals whose key characteristic is that they have lived experience with the communities that they serve. So they have an unusually close understanding of communities, and that's could be through shared ethnicity, shared culture, shared language, or other dimensions of lived experience. You know, fundamental to the CHW ethos is a capacity building approach. CHWs are leaders, and they aren't kind of telling community members what to do. They're not diagnosing medical problems, but instead really working to motivate and enhance self-efficacy. And also fundamental to the CHW approach is sort of an assets-based framework. So recognition that communities have inherent strengths and leadership that can be leveraged to improve health. The CHW model is very much rooted in community organizing traditions. I have a large team of CHWs that work with me. None of them have health backgrounds. All of them have some kind of community organizing background. And that's organizing sort of conceptualized in a variety of ways. Some of my CHWs have backgrounds in organizing in immigrant communities, around labor movements, but some are very involved as organizers in their faith-based organizations, their local cricket teams or other sports leagues. And so CHWs are really able to leverage both that leadership and trusted connection to communities and bring it to the work that they do. So why should we focus and think about community health workers as a potential model? I think the evidence on their kind of effectiveness is very strong and continues to grow. Studies have demonstrated that CHWs can work with community members to improve sort of a variety of health outcomes, kind of reduce hospital readmissions, that it's a cost-saving approach, can help to improve health behaviors. But I think, most importantly, if we kind of go back to our social determinants analogy, we can understand CHWs as that kind of connector between community members living in their local context, and to that connector between those local contexts to other contexts, health promoting contexts. So, I often talk about CHWs using the metaphor of a bridge. CHWs are a bridge between communities and the healthcare system specifically, but also between communities and other systems of care more broadly. So I'm going to tell you a little bit about how we've implemented and thought about the CHW approach in our work. And kind of these three bodies of work have really informed our research. So the first is, everything that we do is very much rooted in community engaged approaches. And I'll describe sort of how we've built that over time. My particular focus and my particular area of research is also responding to, what we know of as noted kind of disparities that Asian Americans face in terms of diabetes and other cardiovascular disease risk factors, particularly in the South Asian community. And then, as I mentioned, kind of building upon the really growing literature on the impact and need for models that link clinic and community settings. Okay. So, we've used the CHW model to really develop a suite of interventions that have, kind of tested the efficacy of working with community health workers in a variety of different settings, in clinical settings, community settings, to improve a variety of different outcomes: diabetes management, diabetes prevention, hypertension management, and other related risk factors. I am showing this graphic because I hope it conveys how our studies have built upon each other over time. And we've used each as an opportunity to really expand our reach across diverse South Asian immigrant communities. So the Asian American community is itself an umbrella category, including a variety of different ethnic groups. The South Asian community is similarly quite diverse, with individuals tracing their heritage back to India, Bangladesh, Pakistan, but all other parts of the South Asian diaspora as well. And so it's been important that we've been able to use this infrastructure to really expand our reach across diverse populations in New York City, including working with the Indian, Bangladeshi, Pakistani community, also increasingly the Nepali community, as well as the Indo-Caribbean community, which is quite extensive here in New York. So I'll walk you a little bit through, kind of the journey of these various studies over time. So our work began in 2009 with the DREAM project, which you see on the kind of left-hand side of the screen. This was a project that we initiated in partnership with a coalition of community-based organizations that were serving the South Asian population, and in partnership with Bellevue Hospital, which is New York City's largest safety net hospital. It also happens to be NYU's teaching hospital. And it really emerged because attendings in the primary care clinic at Bellevue came to us and said, for whatever reason, I think due to the way subways come into Bellevue Hospital, we are seeing a huge influx of Bangladeshi patients in our primary care clinic. And we feel not equipped to work with them in a culturally appropriate way. There's very high rates of limited English proficiency. There seem to be kind of cultural traditions and norms that are impacting their health status. And also we're seeing, you know, almost everybody in our primary care clinic who's Bangladeshi has diabetes, uncontrolled diabetes. So can you work with us? And at the same time, I had been building a coalition of these South Asian community-based organizations. And so we kind of brought those two partners together. And it was really at the urging of our organizational partners who really emphasized, you know, there are some real assets in our community. There are leaders in our community who can help play that connector role and help enhance the healthcare experience of patients. And so it was really from our CAB that the CHW model was conceptualized and really driven forward. And so in the DREAM project, we worked with our CAB and Bellevue Hospital to implement a CHW-led intervention that promoted diabetes management. It was culturally tailored, linguistically tailored for the Bengali population. As we were working in Bellevue, in our CHW's experiences, meeting with patients, getting to know them and their families, they were learning that, yes, many patients came into Bellevue, particularly, you know, this was pre-ACA, you know, very, very large rates of uninsurance in this population. At that time, there was something called HHC options, which was sort of a sliding scale program to access care. So they were learning from patients that, yes, they saw doctors at the primary care clinic of Bellevue for certain needs, but they were also sometimes simultaneously also seeking care in community-based primary care practices in the neighborhoods in which they were living. So the Bangladeshi community in New York City is concentrated in areas of Queens, like Jackson Heights and Elmhurst, Brooklyn, like Kensington, and the Bronx, including Parkchester. And so our CAB really encouraged us to think about building partnerships as well with those community-based primary care practices. These PCP settings were very much, I describe them as sort of mom and pop shops. You know, they tend to be staffed by one physician, an office manager, and maybe a part-time medical assistant. They see a largely Medicaid population or uninsured population. And many times the physician is of, you know, the community-based sites is of a South Asian background. And so community members were seeking care in those settings as well. So building on the sort of first iteration of DREAM, we expanded our work for DREAM into those community-based primary care practices. And in Project Impact, really expanded that network of community-based primary care practices. So we engaged a network of about 20 practices across New York City in both Queens, Brooklyn, and a couple in the Bronx to expand upon our model of working with CHWs and address hypertension management. We then moved on to kind of expanding that network even further and worked with patients to address both diabetes management as well as prevention. And then we've been able to replicate this model into other contexts and settings. And so I was approached in, it was probably 2018 or so, by a primary care physician at Emory who was working in their network of federally qualified health centers. And she came to me with a very similar story to what we heard in Bellevue. You know, there was a large influx of Bangladeshi patients in our primary care clinic, very high rates of diabetes, and we'd love to think about how to replicate the kind of model that you've built into this context. And so we were able to do that in Atlanta. And really excitingly, most recently, we're now sort of taking that work nationally. And so building on the work in Atlanta, being able to demonstrate that we could replicate this in other contexts, we're now expanding that model to upstate New York and several other states in the Southeast where there's been really huge growth in the South Asian population. So, you know, the intervention components across our projects are summarized here. And you can see that there's many similarities across the various projects that we have implemented. And, you know, we used an RCT design or a stepped wedge design in each to test the intervention effectiveness. And there are many common components in terms of the modality. And you can see that they've been implemented across a variety of types of settings that I discussed. But here, you know, I just want to go into a little bit what the similarities across both our curriculum and the model that we've used. So in working with community, you know, there's sort of a a two-level approach that we've used. One is working with practices and enhancing their capacity to be able to effectively kind of integrate CHWs into their workflow. And the second is having CHWs work directly with communities and in community settings. So for the first component, we really worked with practices. Again, think about they're small practices in terms of staffing, very low resource. They tend to have huge patient volume though. All of them now are on an electronic health record, and we're rolling out onto an electronic health record when we began working with them, but really needed a lot of capacity building, training, technical assistance, be able to effectively utilize that tool to manage their patients. And so the first part of our intervention was really working with the practices to enhance their capacity to do that. And with that, kind of introducing the CHW model into their practice and working with providers in particular to provide perspective on how the CHW could be a complement to their team. And for the CHW component of the intervention, you can see, as I mentioned, we really expanded our reach across time. So we developed a culturally and linguistically tailored intervention. So the intervention is delivered in language. It's culturally adapted, and we've reached Bangladeshi, Pakistani, Indian, and Indo-Caribbean community members. That should also say Nepali. Our materials are translated into Bengali, Urdu, Punjabi, Hindi, and of course they're in English. And each of the interventions, the kind of overall structure is that we offer group-based educational sessions, really as a mechanism for facilitating connection and social support. But we also have a lot of one-on-one work that CHWs do with patients as well as family members. And that's through phone calls, home visits, and just more broadly kind of meeting community members where they are. So, I think we often think about the CHW model as an interpersonal model or sort of an individual level model. But it's been really important for us to conceptualize this as really fundamentally a multi-level model. So yes, at the individual level, CHWs are playing a critical role, providing culturally tailored health education, linguistically tailored access to care and navigation. You think about a place like Bellevue Hospital. I don't know how many of you have been there. It's a very grand setting, right? It's very large. It can be extremely overwhelming for a new immigrant just arriving in New York City, probably coming from a context where they didn't even have to have health insurance, really navigating both the physical space, but also the sort of administrative process of accessing care here. And so CHWs play a really critical role at that level, kind of providing that navigation. But also at the individual level, really using an empowerment approach and working with community members to enhance self-efficacy. And this is both around health and sort of non-health types of things. And I'll give you an example. Our CHWs in working with community members found that particularly with female members, they often felt like they had to rely on their male family members to accompany them to doctor's appointments. And if you think about the population that we're working with, so many of our community members are concentrated in low-wage service sector jobs, things like taxi work, restaurant work, street vendors, working in retail. And so, work is very non-standardized. There tends to be very long hours. That's wages lost, right? If a male family member is taking time off to accompany their female family member. And so part of what our CHWs do is work with community members to this is a subway map, and really using strategies to translate, not just linguistically, but using other tools to really translate how to read the subway map, making connections between community members who live in close proximity to be able to create buddy systems, for example, to bring them into appointments, and just more broadly, kind of building self-efficacy to be able to do those things more independently. And then finally, also at the individual level, our CHWs play a really key role. Remember, I described CHWs as being kind of a bridge between communities and healthcare systems, but also communities and other systems of care. And with the populations that we work with, kind of connections to immigration services, legal services, other types of social services like English language classes, employment, have been critical. It's really most often a starting point for our community health workers in working with patients to, diabetes management comes, way down on the list, right, after many of those other things. So that's at the individual level, and it's a critical part of what our CHWs do and a critical part of this model. But remember that CHWs, their key characteristic to me is that they are community leaders. And because they're leaders, because they have the lived experience of communities and they have a keen awareness of community resources, they are really able to, bring their organizing skills to create more positive health promoting contexts. And the ways our CHWs have done that in the context of the types of studies that I'm describing are things like working with faith-based organizations to create, for example, more culturally relevant physical fitness opportunities, working with ethnic grocery stores to work on product promotion of culturally relevant healthy items, working at the neighborhood level to create play streets, for example. And then finally, just kind of thinking about that capacity building approach, I have a team of CHWs who I've hired directly, but we've also worked directly with our community-based organizations to hire and embed CHWs within CBO settings. And that is in itself a capacity building approach. And I've seen kind of how that's evolved over time. So in some of our early studies, we hired CHWs who were embedded into CBOs. That was right on the cusp of kind of Affordable Care Act. Once the New York State Health Exchange was rolled out here in New York, there was a huge push to do facilitated enrollment into the New York State Health Exchange. Who's better suited to do that than kind of CHWs that are embedded in CBOs and already have that kind of trusted relationship and connection? And so it was also an opportunity for our community partners to leverage those resources, right, to be able to support and grow and build their team and staff. And then finally, kind of thinking a little bit more upstream, CHWs have a really important role in working with policymakers and making kind of more systemic changes. And I've seen this happen in a variety of ways. The most impactful in my mind is, I'm not sure how many of you have worked with CHWs before or know the model. So if you have worked with CHWs, you know that one of their greatest skills is that they are skilled storytellers. And I think that's because they both bring the lived experience that they have, but they're also, they have all of the stories of their community members and peers to share. And with policymakers, I think, yes, data moves them, but stories are often much more impactful and moving. And so our CHWs have played a really key role in policy efforts. They're part of both local, regional, kind of statewide, as well as national coalitions to really bring their own perspectives to policy initiatives. But also our CHWs have done a lot of work in making the health system more responsive. And that's through, implementing things like trainings, kind of cultural humility, cultural competency trainings, but really also just encouraging health system leadership to make the system more responsive through better collection of race and ethnicity data, better understanding of who their patient populations are, et cetera. So what have we found through all of our studies? I think we've learned a lot of important things, both on the impact that CHWs can have, but also on implementation. And I'm really going to focus the last part of my talk on that after I go over some results. So, we found that our CHW model has improved diabetes control over time. So compared to in a randomized controlled trial design, compared to individuals in the treatment group, individuals in the control group, individuals in the treatment group were more likely to achieve diabetes control at 6 months. Hemoglobin A1C is a measure of diabetes control. We've had similar findings for blood pressure control. So we actually found that individuals who worked with a CHW over a 6 to 8 month period were 3 times more likely to achieve blood pressure control at study follow-up. And then we also, because of the way NIH is structured and designed, we have to develop studies to, at least from a grantsmanship perspective, to focus on a single health outcome. But we know, for example, that diabetes and hypertension are often comorbid conditions. And of course, community members in our studies, many of them who had diabetes also had hypertension, many of them who had hypertension also had diabetes. And so we thought, we're targeting the same kind of social risk factors, same behavioral risk factors. So we've pooled data across our studies to really look at the impact of comorbid diabetes and hypertension, and found that among individuals who had both hypertension and diabetes, individuals that worked with a CHW were more likely to achieve blood pressure control at study follow-up. As I mentioned, we've replicated this now to other contexts and really excited to now build upon this work in other studies. This is a paper that just came out this week, I think, with my colleague Megha Shah at Emory, who, it was like a really beautiful collaboration that resulted from this, and has continued to expand and grow. But we were really able to see a huge impact of this intervention in the Atlanta population. But then thinking too, just about not just about kind of health outcome impacts, but thinking about other impacts. Our CHWs play a critical role in facilitating connections to social services. So this is probably no surprise to any of us, given this population and what we know about social determinants and their impact on diabetes management and care. Some of the top social needs identified by community members that we worked with include unemployment, access to English language classes, again, very high rates of limited English proficiency in the community we work with, and addressing food insecurity. And you can see, this is some of our tracking data. These are social service referrals made and acted upon. So, we've had a important impact in both making referrals and helping to secure services. So what have we learned from this culturally adapted model? I would say the number one question that I get when I give a talk like this is great, but how generalizable is this model? Because you're working in this very specific community, in a specific setting in New York City. So I guess the first thing I would say is that question comes from a sort of very particular ideological perspective, right? We have a huge body of literature on evidence-based interventions that were developed in a majority white population, and we don't question, their relevance or generalizability to other communities. So just having said that and putting it aside, I think some of what we've learned, I think that can be really critical in informing, informing generalizability are first that, I think we found it's so important to have cultural congruence between the patient population that a system is working with and the CHW workforce. And I'll tell you, this is something that health systems don't want to hear because it's hard, right? They deem it as hard and expensive, and we can never meet the needs of every patient population. But I would say that even getting close, and I think we're at a point where we haven't even really gotten close, So I think it's an important point that's worth making. I think there's a lot of exciting work being done in the second bullet, which is, really thinking about adaptation to social and cultural contexts. Every aspect of our intervention was both linguistically adapted, culturally adapted, and very much socially adapted, so really thinking about the work context that community members are coming from, the living environment that they're coming from. We tend to work in a community, or we work in a community that tends to live in multi-generational housing here in New York City, multi-generational families. And so we've had to really adapt our approach, our curriculum, our strategies for building relationships with family members with kind of that in mind. And then I am excited about where we're moving towards, which is really thinking about, how do we use this model not just to improve one outcome, but thinking about kind of multiple risk factors and multiple outcomes across populations. So I want to spend, my goal is to really wrap up by 12:45, which I think we'll be able to do. because I'd love to take questions and have a discussion with all of you. But I want to spend the last part of our talk on really thinking about what drives implementation success. So this is the number one thing for me. This is my team. And it's like different iterations of folks, and it's my team and my partners, my community-based partners. It's impossible to get one picture with everyone, so I put up a couple different ones. But you know, I really think of our work as for us, by us. You know, I've built the team that's been built is really reflective of the communities that we're serving or working with, and you know, we've made a pointed effort to hire leaders, you know, from the community to really build and sustain that infrastructure over time, which I'll tell you is hard to do in this wacky, you know, soft money NIH funded environment that we have. I've had to hustle to do it. But it is possible. And I think it's the only way. You know, there's so much attention now on diversity in research, diversity in clinical trials. How can we enhance trust in communities? I think until our research teams are reflective of communities in this way, it's, you know, we're never going to get there. Another piece of this for me has really been thinking about sort of career ladders in the context of research teams, in the context of health systems, and for community health workers and related staff. So one of the things I'm very proud of at NYU is that we've been able to build a CHW career ladder, so they're not, you know, kind of stuck in a CHW position for 10 years at a time. You know, many of the folks in these photos have been working with me for 15 plus years. And so we've created ladders that recognize CHW leader roles, CHW trainer roles, and others like that. And I do want to give a shout out to, you know, an important part of our efforts has really been engaging students and trainees from the community as well. Thespia is here, who's worked with us in the past. There's another Thespia who is, I don't think she's here today. She is an SMS MPH student. We've worked with a number of SMS students over the years, but really students from all across the city who are, you know, again, really reflective of the communities that we're working with. So what else drives our implementation success? You know, it's really centered in the idea of CHWs as being a complement to the healthcare team. CHWs help physicians and other members of the primary care team interpret problems and develop action-oriented solutions that really take patients' life circumstances into account. A patient is a patient for 15 minutes at a time at best, right? That you're sort of lucky if you get 15 minutes with a physician. And I think because of that, because of the way our financing is structured in healthcare, the time is structured, and you know, for a variety of reasons, but you know, I think there tend to be these generalizations that are made about patients. They're stubborn, they're non-compliant, they're no-shows. You know, we made appointments, they're no-shows. This patient, there's just no way that they'll exercise. I can't tell you the number of times, you know, we've built this infrastructure with our network of primary care physicians. When we first meet with them, you know, I go out to Jamaica, Queens, meet with them, describe the program. They're like, I mean, that's great, but they're, you know, I know these patients. There's no way they'll exercise. You know, believe me, I've talked to them about how important it is. I mean, this is great what you want to do, but there's no way they'll exercise, you know. So there are these kind of generalizations that are made by members of the healthcare team, and CHWs can really help contextualize those problems, both because they can work with patients outside of the clinical setting, but because they're bringing that lived experience as well. So some of the ways that we've done that in our studies is listed here. But, you know, the other piece that's really driven implementation success for us is our community engagement approach. And I really think of it in this kind of cyclical way that it's demonstrated here. So we have really always tried to work on community-driven priorities that have been identified by our community advisory board. I didn't describe a lot about sort of our early work. A lot of our early work was around characterizing kind of needs and assets in the community. And there, a big focus of that was that there is such limited data on Asian American populations and other quote unquote small populations or invisible or stigmatized populations. And so there's a lot of primary data collection that we did, a lot of use of kind of innovative sampling strategies, ways of combining data across years from federal and local sources to be able to aggregate. So we did all of that in collaboration with our community partners to really inform what they knew was the problem, right? I mean, community members always know what's going on. Community leaders, they know what the problems are, but if they don't have the data to be able to demonstrate that, it's really hard to bring resources to those issues, or to move things forward. So really, working with our CAB to identify priorities, working with them on the cultural adaptation of, evidence-based strategies, and really identifying community strengths, resources, and assets. And, our CBO partners have played an important role in that, but our CHWs have as well. They're members of our CABs. They really bring their expertise, and the work that they're doing with community members on a daily basis to shape our curriculums and protocols. We've also established referral, we in this process kind of establish referral networks between our CBO partners and the community members we're working with. And then really, embedded in all of this is enhancing, building, sustaining community organizational capacity. And I'll give you some examples towards the end of my talk on kind of how we've done that. The other key that was driving implementation success is patient engagement. And I've mentioned some of this during the talk, but some of the strategies our team and the CHWs in particular have used to do that is to use kind of strategies to enhance self-efficacy, self-esteem, provide referrals to needed social services, really engaging the family. So most of our interventions were in kind of individual level interventions. We were working with single patients or community members, but all of our interventions really engaged families in the approach. And that's really throughout the process. We found that engaging family members during recruitment was critical. Like if we wanted to recruit grandma into the study, you better believe that we had to engage, grandma's son and daughter-in-law in the process, all the way through implementation, when our CHWs were doing home visits, really working with the whole family to think about, kind of like if they were talking about something like cooking, for example, working with the whole family to kind of have that conversation and bring them into the conversation. Meeting them where they are, I just want to kind of emphasize that, I use this term home visits, and many of the times our CHWs did do home visits, but they also largely met them where they were at. What does that mean? It could mean meeting with a taxi driver in his cab, on his 10-minute break as he's pulled over, to use the restroom, for example. So like really, thinking about or meeting people at their place of work, meeting them at their place of worship, for example. So, really thinking about the spaces and places that community members are. And then finally, practice engagement. We've had a lot of success working with community-based primary care practices. And, a key part of that has been being a additional resource and extender for the practices in many ways. So, our CHWs are providing assistance to the office staff that's sometimes, out of scope of the research project. So they're the eyes and ears for the patients in many ways, right? So if addresses change, if there are red flag issues going on, our CHWs were part of team huddles to be able to inform the practice staff of that. I've already talked about kind of some of the capacity building approaches that we've used, and then, really thinking about ways to facilitate appointment keeping. You may have noticed that our implementation of a number of these studies fell right smack in the middle of the COVID pandemic. And so it really, like many of us in the room, it forced us to kind of shift to telehealth approaches. And so there's a lot that we've learned about digital engagement and strategies to enhance digital equity in this population. Really tapping into existing platforms that our immigrant communities are using. So, connecting to apps like WhatsApp and others that are more familiar in community settings. Making, again, a family-based approach was really important to enhancing digital equity and, really being flexible with how we're delivering pieces of the intervention. So I want to give a quick shout out. We are studying this using a really exciting kind of mixed methods approach longitudinally over time. This is embedded in implementation science frameworks. This is work that one of our postdocs is leading, Shamir Ali. He's a postdoc at the National University of Singapore right now. But we've been able to, through interviews with stakeholders over time, really from the beginning of the study, and then on an annual basis, really understand kind of what this longitudinal implementation process has looked like, how it's evolved in the context of what's going on. COVID is one of those contexts, but many other contexts as well, thinking about, anti-immigrant rhetoric, policy changes, all of those factors that have, played a role in the implementation of this study. So this is ongoing work. These are some of his early findings that he presented at the D&I conference last year, but really excited to see this come together as well. So what's on the horizon for us? We were testing a model for equity. I see our work as testing a model for equity, but I know that to advance equity, it really requires dissemination, replication, and scale. And so we're making efforts to try to move in those directions, certainly by, informing the quote unquote evidence base, really ensuring our work is included in the CDC's community guide. It's going to be a part of the NIH HD Pulse initiative, which is a repository of sort of equity-oriented evidence-based interventions. We've been working on policy translation, developing policy briefs, informing CHW legislation. Dissemination is really key for us. Of course, yes, disseminating through the peer-reviewed literature, but really thinking about community-based dissemination through community forums, through media, both mainstream as well as ethnic media. We have a really robust ethnic media infrastructure in New York City, particularly in the South Asian community. It's a community of journalists, that are a community of writers. They bring that sort of experience with them. And so we've built really important sustained collaborations with ethnic media to ensure that our work is going back to communities. And then finally, we're thinking about healthcare setting translation right now. So, this is sort of what I see as our translational arc. It's really rooted in community capacity building. You saw that we moved over time into thinking about how we integrate clinic and community settings, but with this goal of creating a sustainable model for health promotion that really centers community engagement and equity. So some of the health system initiatives, and we can talk more about this if you're interested. These are sort of on the horizon, but we're working with NYU right now to actually implement a centralized CHW model in our faculty group practices, which is our network of primary care practices, really with health system and payer investment. So really thinking about how can we create and build a centralized model that can be a resource across practices. Many of you may be familiar that CMS now has requirements on social determinants of health screening for patients. That's not a magic bullet, and we have to screen patients. We also have to be able to refer them. And as much excitement as there is about electronic referral platforms, it's likely to fall flat if we don't have a workforce of individuals like community health workers or other connectors to be able to really facilitate and make those warm handoffs to social service referrals. And then finally, this is one of the newest initiatives at NYU. We received a gift from the Bezos family to kind of implement this large scale community clinical linkage model in Sunset Park, Brooklyn. And I think what's really exciting about that is, I don't know how many of you are familiar with Sunset Park, they live in Sunset Park. Um, it's almost predominantly an immigrant neighborhood, about an equal mix of Latinx, Asian American, Russian, Arabic speakers, kind of in surrounding neighborhoods as well. It's a tremendously diverse population, really important community assets, but it's also a very high poverty neighborhood. And you know, there's lots of challenges with accessing care. And so we're taking some of our work to inform this new initiative, which is exciting. In terms of where we're going with community, you know, as I mentioned, you know, all of our process is very iterative, and we, you know, in our CAB meetings, really try to understand from our CBO perspective in particular, kind of what they are, you know, what their kind of main challenges are, what issues they're experiencing in working with clients. Again, I think no surprise to anyone in this room, but mental health has been highlighted as a huge need, both from our CBO partners, but also from our CHWs working with community members. We know that individuals with diabetes tend to, you know, have a disproportionate burden of mental health risk factors as well. So there's sort of access issues in terms of access to culturally appropriate mental health providers, as well as issues around kind of stigma, you know, kind of highlighting and discussing issues of mental health. And so we've worked with our CBO partners, our CHWs, and a network of South Asian mental health providers to do a series of, we call them listening sessions. They're, you know, they're really safe spaces to be able to talk about these issues in ways that are acceptable to communities. And so, you know, we have started that process, and I hope that it can lead to something similar that we've built in our work around diabetes and hypertension, and kind of leveraging this network. We've also done a lot of work to really support community-led research, you know, providing both logistical and coordination support to our community-based organization partners, to lead, you know, both research initiatives as well as policy and other initiatives, and really bring resources to that. You know, especially important in the way that so much of federal funding is structured, right? That really prioritizes academic organizations. And then finally, through the CAB, it's really been a mechanism of bringing CBO leaders together. You know, we can sort of play a bit of a neutral role. You know, that their CBO partners are in a context of very limited resources. They're often competing against each other. And so I found that our CAB and some of the work that we've been doing that I've described here has been a means of being able to facilitate better collaboration between CBO partners. And some of the examples you can see are here. Finally, on the national initiative, I'm going to have to come back to give a talk about this, but this is like hot off the presses, really exciting. We were just awarded a center grant from NIDDK that is really focused on community engagement and diabetes research. And it's, you know, it's a little different in that this is not a research center. I think of it as like a technical assistance center, you know, so really working with both community as well as investigators to support bi-directional research in diabetes equity. So it's a collaboration between myself at NYU, Arlene Brown at UCLA School of Medicine, and Earl Chambers, who many of you may know at Einstein. But more importantly, we have about 15 different academic organizations and 10 regional and national community-based organizations that are part of this effort. It's a national center, including, I don't see them here, but Rachel Shelton and Sandra Albrecht are part of it as well, which is really exciting. Oh, there she is. Hi. So again, we just received the NOA like last week, a couple weeks ago, I think, and are getting this off the ground, but really excited to see where this takes us. So with that, I'm gonna end, there's a lot here, but just broadly, I'll say, none of this could happen without my team, who I've already kind of introduced you to. Our organization, our CBO partners that are listed here: United Sikh, South Asian Council for Social Services, Bactus, India Home, UPNA, and COPO. And then the list below is a list of all of our community-based primary care sites that we work with.
Okay, thank you. What an incredibly impressive body of collaborative, complicated, and series of projects. And I mean this with all sincerity. It's remarkable for only a decade and a half. Really. So, I mean, students may realize research takes a long time. Community engaged research takes an even longer time. And it's just incredibly remarkable. So congratulations. And thank you for sharing. So I know everyone's probably got to run to class, but we can take Sarah, will you let us take a question or two before Dr. Bob's class starts? Let's take a couple. Kavita, and then the person in the back, and you can take the questions from there.
Yeah, sure. I can hear you.
Otherwise, project. You have to turn it on, I think.
So thank you. That was so impressive, and I reiterate whatever.
I can hear you.
Better?
Yeah.
Can you all hear me now? Okay. I feel a little self-conscious now. It's not such an important question, but I just wanted to convey that this was just a terrific talk. But two related questions, really. The first is when we are talking about cultured, tailored, culturally tailored health education and self-care behavior. One of the key things that occurs to me with South Asians and diabetes is their health beliefs, right? So the missing piece in some ways that I wanted to ask you about is people decide on adapting to biomedical models or whatever they take up, particularly with diabetes, based on what they believe in terms of what suits them. And I know with South Asians, I knew with my own grandmother that you would often use fenugreek, cinnamon, bitter melon, a range of things. So I think it's important, it's one thing for community health workers to recommend biomedical models. And also, let's face it, there are a lot of side effects with some of the medication they're being given. And it's quite normal for them to kind of sometimes push back on their medicines, even when physicians have told them that they should take up something. So to me, healthcare beliefs is a key question. And the second related question is, how useful is it for us to think about, this common model with South Asians, which is the disadvantaged migrant patient? When you speak about a disadvantaged migrant patient, sometimes does it get in the way of independent self-care, right? Does it, because there's a contradiction there between saying you come with a life of disadvantage, but we actually are propping you up to be now an autonomous, self-caring patient. So to me, ethnographically, that's a kind of gap that I wanted us to address. So two related questions. Thank you very much.
Sure. Yeah, both great questions. I'll address the first question first. So what I didn't mention is that our intervention was preceded by a huge amount of formative work we did in partnership with community to really understand those health beliefs, cultural beliefs that communities were applying to diabetes management, and to really integrate and celebrate those in our curriculum. And so it's very much, the curriculum is very much framed not as a do this, not that, and not as a replacement, right? We're not saying to replace certain foods with other foods, but really thinking about, what we learned a lot from community. I love that you brought up the bitter melon example. It was one of the first things that came up, was that, what happens here is that we come to New York City, we're in ethnic enclave neighborhoods with a lot of readily available and generally cheaper party foods. We're not eating biryani all the time when we're, at home, but here when we're on the go and it's readily available and cheap, that's what we turn to. And so, really thinking about, promoting from the community's perspective, what are traditional foods, that are health promoting. And I mean, this is just the food example, but since you honed in on that. So, I think we tried to be cognizant of our developing our curriculum in particular in that way. The second question, so I I don't think our CHWs use the disadvantaged migrant framing in building connections to community members or in delivering their interventions. I think part of why that may have come out in my talk is a political one, right? I think for Asian American communities in particular, we're very much thought of as the model minority. The sort of data equity issues both drive that and are a reflection of that. And so we've had to make the case to policymakers to really help them understand that, Asian Americans, one, are not monolithic, and that, there are real structural challenges that some portions of our immigrant community are facing here. I think in terms of how our CHWs use that in their work, it's really bringing that understanding to be able to accommodate communities in ways that are responsive, so I'll use the taxi driving example again. We'll hear from our community partners, well, I'm in a taxi 16 hours a day. I can't, I don't have time to go to the gym, or I'm very much simplifying this, but just for the sake of example. And so, trying to work with them to think of strategies to address that, like parking your taxi a little bit farther away, for example, or incorporating other kind of low intensity strategies that are doable.
I think the point you made about South Asian cohorts not being counted, and needing to find a place and be recognized. I couldn't validate that. And I know you've been engaged with the masala study.
Yeah. Yeah.
That's the microphone.
Oh, hi, my name is Maydeen. I'm a first year MPH student in the SMS department. First, I want to say this is a really great talk, really informative and thought-provoking. My question was about, as someone who's in a leadership position and you have a fair amount of power within your hierarchy structure, what are the ways that you've advocated for increased workforce support, which could be increased pay or maybe complementary access to social support services for the CHW workers, because you mentioned they are part of this community, so the similar issues that impact the patients also impact the CHW workers, so being mindful of their mental health, whether they're supported, whether they're at the capacity to really step into this amazing role. So I kind of wanted to hear your perspective on that.
Yeah. Let me tell you, I could give a whole other talk about that. Yeah, I'll just give you some examples of how we've done that. And it's something I'm really struck by every day in working with CHWs, that their lives are really a reflection of the communities that we're working with, and the same challenges and joys that our communities are experiencing, they are as well. So I'm trying to think about how to do this statistically. In terms of, the CHW workforce, I think needs a tremendous amount of social support and sort of supervision that's really rooted in that supportive model, so a couple of things. One is I've built my research team to kind of build that in, yes, I have a program manager, but I'm trying to hire a program manager, not just who can do my progress reports, but really who brings that kind of empathy and supervisory supportive supervisory skill to our CHW workforce. Structurally, we've done things so I mentioned the career ladder. I've also worked with our HR to really eliminate restrictions around. So when I hired my first CHW, there was a requirement that they had to have a GED, for example. Well, the Nahar, who's in many of these pictures, came to the U.S. as an asylum seeker, a victim of domestic violence, engaged in domestic violence advocacy here, never had her GED from either Bangladesh or from here. You better believe I was still going to hire her, though, so I really worked with HR to kind of eliminate some of those restrictions, to create sort of I think NYU is in a pretty good place in terms of sort of starting salaries and thinking about increases over time, but creating the career ladder sort of helped bolster that. And then we've done a lot of work most recently. I'd say this has been in the last 5 years, particularly, and has, I think, taken a lot more shape since the pandemic, creating sort of support and wellness infrastructure within NYU, again, leveraging some of our health system resources. So that's kind of on that front. But, you know, just to get back to the first part of your question, you know, my mission always, my stealth and non-stealth mission is to bring as many resources to communities as possible. And, you know, I mentioned a hustle, you know, I've had to do that in a variety of ways, you know, but, you know, I've been working towards ensuring our CHWs can be funded through operating accounts, for example, so they're not reliant on grant funding. Created, you know, trying to create more mechanisms institutionally to support some of the community-led research so that resources are going out to CBO settings to support some of that work. So anyway, so that's many different things, but hope that gives you a sort of a sense of what we're doing.
Thank you. I think we're gonna have to wrap since the class is waiting outside. So thanks, everyone.
Thank you. That's a pleasure.
And did you, I realized you knew where your water was.
Yes,
Oh,
I did.
Okay, let's see.